Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everybody. Today's presentation will talk about the classification and general actions of sympathomimetics. These include actions on cardiovascular system and smooth muscles. So the main goal of this presentation, at the end of this lecture, you should know what's the difference between the directly and indirectly acting sympathomimetics. You should know some of the most important examples of directly and indirectly acting sympathomimetics. We are going to discuss as well the effect of sympathomimetics on the heart and some smooth muscles of the body. So we start first with the classification of sympathomimetics. As we have said before, sympathomimetics are drugs which are producing actions similar to the activation of the sympathetic nervous system. They are generally classified into two groups. First group are the directly acting sympathomimetics, and these drugs they act directly on the adrenergic receptors, whether they are alpha receptors, beta receptors, or both. So they are known as directly. So directly acting sympathomimetics are drugs which act as an agonist on the adrenergic receptor, i.e. they have affinity to the receptor, they combine to the receptor, and they have the ability to produce action, i.e. they have intrinsic activity. Okay? These agonists, they differ in selectivity, as we will mention later. They will differ in what type of adrenergic receptor they act as an agonist. In selectivity, some of them they are selective, some of them they are not selective. They act on all adrenergic receptors, and they differ as well in potency. Some of them they are potent at certain types of receptors and with weak potency on another type of receptor. So these are the first group. This is the first group. Drugs which act directly as agonists on adrenergic receptor. The second group, they are known as indirectly acting sympathomimetics. And indirectly, it means they act through the release of noradrenaline. So what they do, they enter the nerve terminal. As you can see here, they enter the nerve terminal. Once they enter the nerve terminal, they displace noradrenaline from the storage sites, causing the release of noradrenaline. Noradrenaline will act on adrenergic receptor and produces the action. So this second group, indirectly acting sympathomimetics, they act indirectly to the release of noradrenaline. Therefore, we can say that for these drugs to produce action, they should meet three prerequisites. First, the presence prerequisites. What should be available for these drugs to produce an action? The first prerequisite, that there should be a nerve, of course, because they have to enter the adrenergic nerve terminal to release the noradrenaline. Therefore, the first prerequisite, the presence of adrenergic nerve. They act through the adrenergic nerve. The second prerequisite, that they should be uptaken into the nerve. They should enter the nerve terminal. They should enter the adrenergic nerve terminal. How they do that? How they enter the adrenergic nerve terminal? They do that through the uptake one mechanism. As we have said in the last lecture, there is a specific mechanism for the reuptake of noradrenaline after its release. Its inactivation is done by reuptake into the nerve terminal. This is uptake 1. We called it uptake 1 mechanism. These drugs, to enter the nerve terminal, they enter through the uptake 1 mechanism, which is an active process, as we have explained in the previous presentation. So first they will be taken up into the nerve terminal using the same uptake 1 mechanism. A third, there should be a stored noradrenaline. Storage vesicle, as we have said, noradrenaline is stored in the storage vesicles, as we have said in the last presentation. These drugs, they should be noradrenaline stored so that they can release noradrenaline. They can release noradrenaline. They displace noradrenaline. They like the place of storage of noradrenaline. They ask noradrenaline to leave, and they displace noradrenaline from its storage sites. Displace noradrenaline. Once they displace noradrenaline, they will be released, of course. Noradrenaline will be released at the synapse. Okay? So these are the three prerequisites for indirectly acting sympathomimetics. First, there should be adrenergic nerve available so that they can enter to the nerve. Third, should be stored noradrenaline so that they can release noradrenaline from its store. Okay, this is known as displacement of noradrenaline, causing noradrenaline release. Therefore, we expect that the action of indirectly acting sympathomimetics will disappear, or they produce no action if there is no adrenergic nerve terminal, or if there is no uptake, or if there is no stored noradrenaline at the storage sites. Okay, so these are the general property of indirectly acting sympathomimetics. They enter the nerve, they displace noradrenaline, and they cause the action through noradrenaline. Okay, so what's the difference between indirectly acting sympathomimetics and directly acting? What's the difference? The first difference we are going to talk about is the mechanism, as we have said. Directly acting, as we have said, they act as an agonist at the adrenergic receptor, i.e. they have an affinity to the receptors, to adrenergic receptors, whether they are alpha or beta, and they have intrinsic activity. Of course, as we have said, they differ in selectivity and they differ in potency. In indirectly acting, they act through the release of noradrenaline, as we have said. They enter the nerve terminal and they cause the displaced noradrenaline from the storage sites, and they cause the release of noradrenaline, and noradrenaline will produce the action. That's why we call them indirectly. غير مباشر، تأثير غير مباشر. Second, when we inhibit the uptake, what will happen? As we have said, at the adrenergic nerve terminal, there are active uptake mechanisms which reuptake noradrenaline after its release, and it's like this. We said it is uptake 1 mechanism. We call them uptake 1 mechanism. So in this case, if we inhibit the uptake by drugs like imipramine, what will happen? Imipramine is a tricyclic antidepressant, as we will say later. It acts by inhibition of the uptake of noradrenaline. So what will happen in this case? If we inhibit the uptake of noradrenaline, what will happen to noradrenaline, which is a directly acting sympathomimetic? What will happen to its action? Of course, in this case, it will stay longer at the synapse because it will not be reuptaken, which we said it is the physiological inactivation of noradrenaline. So directly acting will stay longer at the synapse. That means their action will be increased. So we will expect by inhibiting the uptake 1 mechanism, the action of directly acting sympathomimetics like noradrenaline and adrenaline, their action will be increased. Why increased? Because we inhibited their physiological inactivation. Indirectly acting, in this case, they cannot enter the nerve terminal because, as we have said, they enter the nerve terminal to the uptake 1 mechanism. So if we inhibit the uptake, they cannot enter the nerve terminal. If they cannot enter the nerve terminal, they cannot replace noradrenaline from the storage sites. Therefore, they produce no action. Their action will disappear. Their action will disappear. تأثيرهم هيختفي، مش هيكون لهم تأثير. ليش؟ لأنهم ما يستطيعوش يدخلوا النهايات العصبية. Therefore, By inhibiting the uptake one mechanism, indirectly acting will lose action. They can produce no action. Why? Because they cannot enter the nerve terminal. The same thing happens if we deplete noradrenaline stores. As we have said, noradrenaline, after its synthesis, it is stored in the storage vesicles. Storage vesicles. We call them storage vesicles. حويصلات التخزين. Therefore, if we destroy these storage vesicles, what will happen to noradrenaline? Noradrenaline will be metabolized by MAO. As we have said, in the nerve terminal, there is monoamine oxidase. Monoamine oxidase, its function is metabolize, oxidizing noradrenaline and adrenaline and 5-HT as well, and dopamine. Therefore, by inhibiting MAO, by destroying the storage vesicle, MAO will metabolize noradrenaline. So what will happen in this case? What will happen? In case of directly acting, still, because they act directly on the receptor, therefore their action will not be affected. Therefore they produce action. They can still produce action because they act on the adrenergic receptor on the postsynaptic membrane. They have nothing to do with the presynaptic nerve terminal, okay? So directly acting, they still can produce action. But indirectly acting, once they enter the nerve terminal, they found nothing to be released because noradrenaline is depleted. Depleted means تفريغ بالعربي. Depletion means removal of the content. There is no noradrenaline to be released. So what will happen in this case? They will enter the nerve terminal and they found nothing to be released, so they will produce no action. Their action will disappear. Okay? So by depletion of noradrenaline stores, by reserpine, for example, it's most famous. We'll talk about it, inshallah, next presentation or the presentation after. Reserpine is an alkaloid which destroys the storage vesicles of noradrenaline, depleting noradrenaline stores. Depleting noradrenaline stores, that means there is no noradrenaline stored, and indirectly acting will lose their action. Okay, so this is the third difference. Next difference, suppose we inhibit MAO. If we inhibit the enzyme responsible for the metabolism of noradrenaline, as we have said, MAO is the enzyme responsible for metabolism of noradrenaline. What will happen if we inhibit MAO? So we have the storage vesicles like that. Okay, we said that noradrenaline, after its synthesis or uptake or synthesis or reuptake, it will be stored in the storage vesicles. If it is not stored, as we have said, there is MAO, an enzyme active in the cytoplasm, floating in the cytoplasm. Once it finds free noradrenaline, it will break it, it will metabolize it. Okay, now if we inhibit MAO, that means any amount of noradrenaline uptaken, reuptake from the synapse or synthesized, synthesis, all of it will be stored. So the amount stored, what will think will happen to the amount stored? It will be increased, increasing the amount of noradrenaline stored. Okay, so therefore, by inhibiting MAO, monoamine enzyme, that means all the amount of noradrenaline sensitized or reuptaken from the nerve terminal will be stored, i.e. will increase the amount of noradrenaline stored. So what will happen to the action of directly acting? What the directly acting will produce in this case? What will happen to the action of directly acting? Directly acting, as we have said, they have nothing to do with the nerve terminal. They act directly on the adrenergic receptor. They act directly on the receptor. So therefore, in this case, their action will be the same. Action is the same. Why? Because they act on the receptor. They have nothing to do with the amount of noradrenaline stored. But in case of indirectly acting, as we have said, indirectly acting, they will enter the nerve terminal. They will enter the nerve terminal first, and then they displace noradrenaline. They displace noradrenaline. In this case, they will displace small amount or large amount of noradrenaline. Of course, they will displace large amount, larger than expected. So what will happen in this case? Their action will be greatly increased. Increased action. Okay? Their action will be greatly increased. Okay? So by inhibiting MAO, monoamine oxidase, which is present in the cytoplasm, most of noradrenaline sensitized and reuptaken will be stored in the storage vesicle. That means the amount stored will be large amount will be stored. Storage vesicles will be filled with noradrenaline. Directly acting, of course, they act on the receptor. They have nothing to do with the nerve terminal. So their action will be the same, will not be modified, will not be increased or decreased. But the action of indirectly acting will be greatly increased. Why? Because once they enter the nerve terminal, they found an enlarged storage vesicles causing release of large amount of noradrenaline. Large amount more, we have said that they produce the action. So their action will be greatly potentiated. Okay? So by inhibiting MAO, the action of directly will not be changed, but the action of indirectly will be greatly increased. Okay? So this is the fourth difference between the two groups. The fifth will difference before the last. The fifth when we do denervation. Denervation means removal of the nerve. Denervation, what does it mean? It means removal of the nerve. Denervation. Denervation means removal of the nerve. So what will happen if we denervate? There is no, so we destroy. So as we have said, this is the nerve terminal which stores noradrenaline, and this is the adrenergic receptor on the postsynaptic membrane. This is the alpha receptor and beta receptor which are present postsynaptic membrane. If we denervate the nerve terminal, we destroy the nerve terminal. So what will happen in this case? What will happen? That means directly acting, their action will be increased action. This is due to the phenomena of known as supersensitivity. Denervation, supersensitivity. Denervation, supersensitivity. So, what does it mean, supersensitivity? This is a general phenomena which takes place at any neurotransmitter when the nerve is removed, whether chemically or surgically. Usually the postsynaptic receptors, they will be increased in sensitivity in a process known as hypersensitivity or supersensitivity, and increase in number in process known as upregulation. Okay? So, when we denervate any nerve, what will happen to the postsynaptic receptors? Their sensitivity to that neurotransmitter released will be increased, and their number will be increased. This is known as denervation supersensitivity. So in this case, receptors, when we denervate the adrenergic nerve terminal, the receptors alpha or beta will become more sensitive to the agonist. So when we administer directly acting sympathomimetic, they will find receptors which are supersensitive. So what will happen to their action? Their action will be increased, will be greatly increased. Okay? So by denervation of the adrenergic nerve terminal, the action of the directly acting sympathomimetics will be increased. What will happen to the indirectly acting sympathomimetics? Indirectly acting, they act as we have said through the release of noradrenaline. Now there is no nerve terminal. The nerve is removed, nerve terminal is removed. Therefore, they will find nothing to be released. So they will produce no action. They produce no action. Okay? So this is where they will lose their action. This is the fifth difference between directly and indirectly acting sympathomimetics. The last difference we are going to talk about is what will happen if we repeatedly administrate these drugs over a short period of time. So what will happen if we give these drugs repeatedly over a short period of time? Of course, directly acting, they will find the receptors present, so they produce action. So action will be there, it will be the same action, same action. What will happen to the indirectly acting? Indirectly acting, their action will start to disappear. Why they start to disappear? I will explain that. So their action will start to disappear slowly or decrease in action. Action will decrease gradually till completely no action, till no action is produced. Okay, this process is known as tachyphylaxis. This process is known as tachyphylaxis. Tachyphylaxis or acute tolerance. Tachyphylaxis or acute tolerance. Okay, so what will happen with the indirectly acting? Their action will start to decrease till we reach a point where they produce no action. This is known as tachyphylaxis. Why? Because these drugs, we have said, if you just concentrate with me, these drugs, we said that they will enter the nerve terminal and they will displace noradrenaline. Okay? So when you give the first dose, they will displace some of noradrenaline. When you go repeating the same dose again, they displace more of noradrenaline. Okay, till the point when there is nothing to be displaced, like يحصل depletion of noradrenaline stores. So therefore they will lose their effect after repeated administration over a short period of time. Okay, what are the examples? What are the most important examples of directly and indirectly acting sympathomimetics? Directly acting, as we have said, they differ in selectivity. Some of them they are selective to certain adrenergic receptors, or some of them they are non-selective. Non-selective, that means they will act on more than one receptor. As we see here, for the selective, I have given you for each receptor, adrenergic receptor, a very famous example. Methoxamine is an alpha-1 agonist, mainly selective, and we have to point out here that selectivity is not absolute. That means in small doses or in normal doses or normal therapeutic dose, they are selective, but in enough high dose, they become non-selective. So selectivity is not absolute. Methoxamine, in a normal dose, it is more alpha-1 agonist. Phenylephrine is another most same example. Methoxamine, phenylephrine, they are alpha-1 agonist. Beta-2 agonist, most famous, salbutamol, terbutaline, ritudrine. These are selective beta-2 agonists. Selective beta-1 agonist includes dobutamine, and I might add dopamine, although dopamine is not only very selective, but we have to know that it has a beta-1 action. So dobutamine, it is selective beta-1 action. Clonidine, guanfacine, they are selective alpha-2 agonists, selective alpha-2. As we have said, alpha-2 is inhibitory, Therefore, these drugs, they are not sympathomimetics, they are sympatholytics, because they will decrease the sympathetic activity, as we can say later. They are sympatholytics. Okay? So these are selective sympathomimetics. Non-selective sympathomimetics, including the foremost same example, adrenaline. Nobody forgets adrenaline, which is known in America, or in American name is epinephrine. 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 Adrenaline is an agonist at all types of adrenergic receptor, including an alpha 1, an alpha 2, beta 1, and beta 2. Noradrenaline, which is the normal neurotransmitter, noradrenaline or norepinephrine. Noradrenaline, it is non-selective, it is agonist at alpha 1, beta 1, and alpha 2. It has no activity at beta 2. Okay? Third example, isoprenaline, isoproterenol, as it is known in America. Isoprenaline, it is non-selective beta agonist. It acts on beta 1 and beta 2. Okay, so these are the directly acting sympathomimetic agonists. Indirectly acting, there are many very famous groups like tyramine. Tyramine, indirectly acting tyramine, is the content of cheese. It is amino acid present rich in cheese. Cheese is rich in tyramine. Tyramine, it has no therapeutic application. It is a site of drug-food interaction. It is a site of drug-food interaction, as we will talk about when we talk about tricyclic antidepressant and MAO inhibitors in treatment of depression. The second most famous examples are oxymetazoline, and nafazoline, that are used in treatment of nasal congestion, as we will see later. Oxymetazoline and nafazoline. Maybe the most famous examples are cocaine and amphetamine. Cocaine, maruf, well known, and amphetamine, these are both are CNS stimulant. They stimulate central nervous system, they produce euphoria and a lot of other central effects. They produce CNS stimulation. Besides, they have indirect sympathomimetic activity. They cause the release of noradrenaline from the adrenergic nerve terminal. Okay? Now, these are the indirectly acting. Some drugs, they have a mixed action. Mixed, that means they can act as directly and indirectly. They act both as directly acting sympathomimetics, and they act as indirectly through the release of noradrenaline. Maybe the most famous example is ephedrine. Ephedrine, which is a natural alkaloid from the ephedra, well-known ephedrine. Mephenteramine is another example. Mephenteramine. These both, ephedrine and mephenteramine, they have very specific clinical uses. They are alpha 1 agonists. They act as an alpha 1 agonist. On high doses, they act as beta 2 agonist, and they can release noradrenaline from the adrenergic nerve terminal as well. Okay. Now, so these are the examples of sympathomimetics. We talk first about the general actions of this group of drugs. Then we'll talk about the specific action of the individual drug. Okay? So we'll talk first about the general actions on the cardiovascular system and smooth muscles of the body. And we concentrate our talk on the actions which have a therapeutic application. Okay? So first we talk about on the heart, general pharmacological action, their action on the heart. As we know, the heart is rich in beta 1 receptor, whether they are present in the SA node, they are present as well in the AV node, they are present as well in cardiac myocyte or cardiac muscles, especially ventricles. Okay, So what will happen in this case? Beta 1, as we have said, they are stimulatory, always stimulatory. They act through cyclic AMP, and they will increase intracellular calcium, as we have said before. This increase in intracellular calcium will activate the SA node, will increase the rate of SA node activity. That means increase in heart rate, as we know heart rate is controlled by the SA node activity. So by stimulating the SA node, by increasing the SA node activity, the heart rate will be increased. This is known as tachycardia. Tachycardia. Therefore, most of sympathomimetics, their action, they increase they produce tachycardia. This effect on heart rate is known. This known as the effect on heart rate is known as chronotropic effect. Positive chronotropic effect. Chronotropic effect. Okay? So by increasing the heart rate, they produce tachycardia, which is known as positive chronotropic effect. As well, increasing the calcium in the AV node, this will increase the rate of conduction through the AV node, increase the conduction through the AV node, and this is known as dromotropic effect. Dromotropic effect. Okay. Now, therefore, this is the effect on the AV node. AV node activity will be increased. This will result in increased conduction through the AV node. Any excitation which comes from the atria will be conducted to the ventricles. This is done through the AV node. Therefore, if the arterial activity is high, this activity will be conducted through the AV node, and this is known as dromotropic effect, the positive dromotropic effect. Also, by increasing calcium level in the cardiac muscles, they will increase the force of muscle contraction. Increase the force of muscle contraction. And this is known as positive inotropic effect. Positive inotropic effect. Okay. So parasympathomimetics, by acting on beta 1 receptors in the heart, which is linked to S protein, which will activate adenylate cyclase, which will result in the formation of the second messenger, the cyclic AMP, and second messenger cyclic AMP will increase in intracellular calcium through specific mechanisms we have talked about in previous presentation. This increase in intracellular calcium, it has a positive effect on the SA node, increasing the rate of SA node activity will result in tachycardia, which is known as positive chronotropic effect, and as well they will increase the conduction through the AV node. Any activity in the atria will be conducted to the ventricle faster. This is what we said, the dromotropic effect, positive dromotropic effect. Also, the increase in intracellular calcium in the cardiac myocyte will result in increase in force of muscle contraction. This is, we said, it is positive inotropic effect. Okay, all these effects means two things. By increasing rate, conduction, and contraction, this means two things. At first, by increasing contraction will increase the cardiac output. In general, these drugs, they can increase the cardiac output, increase the amount of blood pumped by the heart. They increase the cardiac output through different mechanisms. Except in the very high dose, in the very high toxic doses, they produce the opposite, because they can produce arrhythmia in this case. Okay, so on the normal doses, they can increase the cardiac output. Okay, this is one. Increasing the cardiac output in general can result in an increase in blood pressure. As we have said, blood pressure is the main product of cardiac output and peripheral resistance. Therefore, by increasing cardiac output, there is a chance of increasing blood pressure. Of course, not all of them, they produce increase in blood pressure because of the many of the reflex mechanisms involved. Okay, so the first thing, sympathomimetics, by acting on the heart, there is a possibility of increasing cardiac output. Second, by increasing activity in the heart, all of it, whether it is rate or conduction or contraction, this will increase the oxygen demand, will increase the oxygen demand. This is very famous phenomena. As we know, and there is usually a balance of between the heart demand of oxygen and demand and the supply. There is a balance between supply, blood supply through the coronary artery, which carries oxygen to the blood, and the demand. There is a balance. Once the demand increases, like in cases of exercise or like in cases of administering sympathomimetics, demand increases because it works more. When it works more, that means it needs more oxygen. Once more a demand is increased, supply should increase. Supply should increase. Okay? So therefore they say that the efficiency of the heart will be decreased because it needs more oxygen to do better work. Okay? So these drugs, they will, by increasing the work of the heart, they will increase the oxygen demand. Okay, so by increasing the demand, a supply always should be increased. Suppose there is a decrease in supply, like in cases of ischemic heart diseases, ischemic heart diseases, like angina, like myocardial infarction. Usually supply is limited because of atherosclerosis and other causes. Okay, so in this case, if the supply is not increased, this is dangerous because increasing demand with no increase in supply can subject the person to more ischemic heart disease. That's why these drugs, they are usually contraindicated in ischemic heart diseases. Okay, so this is the general effect on the heart. First, general effect on the heart. So by acting through the beta-1 receptor in the heart muscles or the heart tissue, they will increase activity of the analyze cyclase, increasing cyclic AMP, second messenger, increasing intracellular calcium, as we have said before, cyclic AMP through protein kinase A will increase opening of calcium channels, and the opening of calcium channels will increase in intracellular calcium. This increase in intracellular calcium will increase the heart rate, will increase the conduction, will increase the cardiac contraction. Increasing the output of the heart because of increasing the cardiac contraction, and also increases the oxygen demand. Okay, so this is the first effect on the heart tissue. We will speak about the specific effect of each drug when we talk about the specification of each sympathomimetic. The second effect we are going to talk about general, their effect on smooth muscles of blood vessels, smooth muscles of the blood vessels. As we know, blood vessels, especially resistant blood vessels, small arteries or arterioles, they have both types of adrenergic receptors, beta-1 and beta-2. As we have explained, this is the adrenergic. If we just imagine this is a blood vessel and this is the receptor. For there are two types of receptor in blood vessel. Usually, in most of blood vessels, small arterioles, there are alpha-1 and beta-1. As we have said before, alpha-1 always excitatory. Excitatory means that they will increase in intracellular calcium, resulting in vasoconstriction. This is vasoconstriction. While beta-2, it is always inhibitory, and we have said why they inhibit, why they are inhibitory, which leads to vasodilatation. Okay, so alpha-1 is always excitatory, which leads to vasoconstriction, while beta-2 is always inhibitory, which leads to vasodilatation. Alpha 1 usually they are mostly present in the skin and the viscera, internal organ, while beta 2 usually are present in the liver and the skeletal muscle. And this is logic because when the sympathetic system is activated in cases of fight or flight, when the person is exposed to any type of stress, he needs more blood supply to the liver and the skeletal muscle. Liver, as you know, production of glucose, which is needed for energy, and the skeletal muscle, as you know, which does the voluntary activity, and it leads less blood supply to the skin and viscera. Therefore, sympathomimetics, by acting on alpha 1 receptors in the skin and the viscera, they reduce blood supply to these organs, while beta 2 on the liver and the skeletal muscle, they increase the blood supply to these organs. Okay, so this is the first effect on the smooth muscles of the blood vessels. So in summary, we can say that sympathomimetics are either directly acting as an agonist or adrenergic receptors, or indirectly acting through the release of noradrenaline. We spoke about the differences between directly and indirectly acting sympathomimetics. We also talked about their effect on the heart, including positive inotropic, dromotropic, and chronotropic effect, and how they increase the oxygen demand of heart muscles. We talked about their effect on blood vessels and how alpha 1 produces vasoconstriction and beta 2 produces vasodilatation. In our next lecture, inshallah, we'll talk about the pharmacological action of sympathomimetics on other smooth muscles of the body, including the lung, the uterus, and the eye. I would like to thank you very much for your attention. If you like my presentation, don't forget to press like, and don't forget please to share with friends. Please subscribe to my channel. Wish you all the best luck. Wassalamu alaikum wa rahmatullah.